So tonight, I'd like to kick off with Lindsay McCorkle, who is the product manager at Specialeyes. So she's one of the folks who's responsible for bringing this new OptiSync technology to the market. And I'd like to start with her because she's going to give you a little bit of an overview and introduce you to our speakers tonight. So Lindsay, why don't you take it away?
Thanks, Adam. Appreciate it. Good evening, everyone. Thank you so much for spending time with us tonight. We really appreciate it. Like Adam mentioned, my name is Lindsay McCorkle. I'm one of the product managers at Specialeyes. Here with me tonight is our NCLE certified lead consultant, Corinne Andrew Ladajensky. And then our main presenters this evening, who you're going to hear from, are Dr. Matthew Lampa and Dr. Stephanie Ramdass. So I'm just going to give a brief introduction and a little bio, a little background in regards to Dr. Lampa and Dr. Ramdass. Dr. Lampa comes to us from Forest Grove, Oregon. He's an associate professor at Pacific University College of Optometry, where he's involved with specialty contact lens fittings, instruction, and clinical research. He also completed a residency in cornea and contact lenses at Pacific, and he's also an associate in a private practice. Dr. Ramdass comes to us from Toronto, Canada, where she's in a private practice. She's also an adjunct faculty member at Michigan College of Optometry, as well as she completed a cornea and contact lens residency at Michigan College of Optometry and a fellowship in its Vision Research Institute. Dr. Ramdass was also the lead investigator in one of our studies in regards to OptiSync Technology. So you'll hear from her a little bit on that a little later tonight. So on behalf of myself, Corinne, Dr. Lampa, and Dr. Ramdass, again, we want to sincerely thank you for spending your time with us tonight. We know it's super valuable. So our goal is hopefully to deliver some valuable content and practice pearls and nuggets that you can take back to the practice with you. So tonight we're going to let you know what OptiSync technology is. We're going to share with you the data and studies behind it, so kind of our journey. And then lastly, we'll share when and how to fit a multifocal lens with OptiSync technology. I'm going to give you, like Adam mentioned, a brief introduction, then I'll turn the floor over to Dr. Lampa and Dr. Ramdass. So what is OptiSync technology? Basically, the technology allows us to offset or shift the multifocal optics from the center of the lens and target alignment with the patient's visual axis in order to improve their visual experience with multifocal contact lenses. I think it's easiest to think of it as a customization feature of Specialeyes' current multifocal product line. So for those of you who may not be familiar with our flagship product, the Specialeyes 54 multifocal, I'd like to give you a quick overview just so we're all on the same page. The 54 multifocal is represented on the left-hand side of the screen on that image. It's a fully custom aspheric soft multifocal contact lens design. It's available both in toric and sphere, pretty much any base curve, diameter, and power, available center near or center distance. But what really differentiates the design from many of the multifocal contact lenses on the market today is that the multifocal optics within the lens are customizable. We basically customize the multifocal optics according to your patient's pupil size and specific visual needs. Now, as a company, we're just iterating this customization a step further and adding an additional customization to our multifocal product line. And it's that of being able to offset or shift the multifocal optics from the center of the lens. And we're calling this OptiSync technology. And you see that depicted on the image on the right-hand side of your screen. So you see that the white dashed crosshairs represent the geometric center of the lens. And in the image depicting OptiSync technology, you see that the optics within the optic zone are offset or shifted. In this particular example, they're shifted nasal. So they're not in the geometric center of the lens, they were actually shifted to the nasal side within this particular example. You may be thinking to yourself, why in the world would I want to do that? Why would I want to offset the multifocal optics? Well, we're going to talk about that. Let's just talk about the problem that this technology solves. On the screen here, you see an eye and you see that white circle that represents the visual axis. You see the green crosshairs, which represent the multifocal optics, and you see that there's a misalignment there. They're not aligned on top of each other. And so this is the problem that presents. In a perfect world, the traditional way that we currently fit multifocal contact lenses with the optics placed in the geometric center of the lens, that would always ensure proper alignment of the center of the optics with the patient's visual axis. And from clinical practice, we know that many times this approach works. It's really great when it does because we have successful multifocal lens fittings. It's very efficient. but it doesn't always work, and not for all patients. So maybe in this scenario, there's a slight temporal decentration of the contact lens due to the patient's scleral shape, or maybe the patient has a temporally displaced fovea causing them to look way nasal. Regardless of the cause, factors such as these can lead to this misalignment occurring between the center of the optics and the patient's visual axis. And when the misalignment occurs and it's actually great enough, it can cause reduced acuity and unwanted visual complaints such as glare, shadows, 3D effects, etc. And then from a consultative perspective, many times nothing we ever try really improves the patient's visual experience to a point to where they're truly satisfied. And what this does is obviously leads to unhappy multifocal patients with unsuccessful lens fittings for your practice. And a lot of times these patients, you know, when we're working through the fitting process, like, these patients should be a slam dunk success. Why aren't they successful? So the solution that Specialeyes has deployed for this particular problem is OptiSync technology, or the ability to offset the multifocal optics. And when we incorporate OptiSync technology and align the center of the optics, or more closely align the center of the optics with the patient's visual axis, it has actually been shown to reduce vision issues and improve the patient's visual experience with multifocal contact lenses. And as a representative of the company, and as the company, we believe that this technology may be the missing link to some of our multifocal contact lens patients. And I just want to emphasize the key word here is some. It's not the end all be all, it's not the holy grail, but rather we believe it's another layer to that multifocal contact lens story, and a factor we believe that should be taken into consideration when fitting multifocal contact lenses. So now I'd like to turn the floor over to Dr. Lampa and Dr. Ramdass, your main presenters this evening. They're going to be going into more detail with you and discussing their studies and experience with this technology. So with that in mind, Dr. Lampa, go ahead and take it away.
Thank you very much, Lindsay. So one of the issues that Lindsay brought up as a part of this investigation into would offsetting the optics be a worthy consideration in a multifocal contact lens wear is why is it that contact lenses, particularly soft lenses, don't seem to center on the eye? And I got to be honest, in my initial evaluation of soft contact lenses, I very commonly would record in the chart that the contact lens was centered. And I think what I meant by recording that in the chart is that there was something about the edge of the contact lens covering either side of the limbus. But if I took a really careful evaluation and looked at how much of the edge actually covered over the patient's limbus, it would be identified with the slit lamp that there's more coverage temporally than there is nasally. So the question is, if a contact lens decenters, why is it so common in the temporal direction? This isn't necessarily a soft lens specific issue. This is also something that we observe in scleral contact lenses. And when we started to look at this, what our initial analysis of this was actually for scleral lenses with the aid of OCT. And the OCT, the anterior segment specific OCT, really gives us a fairly broad view of not just the cornea, but out onto the surface of the sclera. And if we were to draw a bit of an imaginary line running through the patient's corneal apex, a horizontal line, and then drop down another line and measure where is it that we first meet the temporal sclera, and then sort of equidistant to that on the opposite side, if we were to actually measure the nasal portion, we'd see that if we bring those lines back together in the center over that reference beam, which is lined up when the patient's visual axis lines up in the instrument, we can see that there's a bit of a mismatch, that actually the nasal portion of the sclera is actually higher than it is on the temporal portion of the sclera. And much of the work that we've done at Pacific and other places in North America have identified a similar thing. And actually this effect gets greater as you go away from the center. So the further out you go across the sclera, the greater the mismatch between the nasal and temporal portion of the sclera. So if we were to take an imaginary contact lens, I realize this is a little bit of a cartoon. So if you imagine this blue arc here at the top of the slide as representative of a soft contact lens, and then that yellow star is the geometric center of that contact lens. But if we were to take that lens, instead of having it just floating in free space, if we were to actually drop it down onto the surface of the sclera, what we could see is that it's going to hit nasally first and then get pushed in the area of least resistance, which is actually in the temporal direction. So now we get this temporal displacement of the contact lens, and now no longer do we have the geometric center of the optics aligned with the visual axis as identified by that reference beam on the OCT. So one of the other things that we've learned from the refractive surgery literature in particular is that our pupil isn't actually in the center of our eye. If anything, it's displaced in the nasal direction. So now what we have, if we were to imagine this as a right eye on the slide, we would have our contact lens moving in the temporal direction. Our pupil gets moved opposite. It goes in the nasal direction. And now, as Lindsay identified earlier, due to the temporal displacement of our fovea, we actually look through a nasal portion of our cornea. So we've got these things kind of working to our disadvantage, especially when we're trying to take this fairly complex multifocal optic and get everything lined up over the patient's visual axis and pupil. So in getting things to line up, we basically have two choices. One of the choice is to have the contact lens just align where it's going to align, and it's going to fit where it's going to fit. And then we would ask the manufacturer to offset the optics in the nasal direction. So that would be the scenario in the top left-hand side of the screen. One of the other options would be to, through some sort of sophisticated lens design, get the contact lens to actually decenter in the nasal direction, which is a very difficult thing to do. So one of the ways that we can actually start to image what is it that the patient might actually be seeing is through the aid of corneal topography. And there's some unique things that we can do with our corneal topographer to get an idea of where these optics are placed in relation to the patient's visual axis and their pupil. So when the manufacturer places the multifocal optics into these soft lenses, they're placed on the front surface of the contact lens. So that makes them accessible to the topographer as the patient's actually wearing the contact lens. So this is a tangential display with the corneal topographer, and up on top we have two images. We have a right eye and a left eye, and the center of the map is essentially what we're saying here, what we're calling the visual axis. That's where the patient's looking straight ahead. So that's that white star that you see in the middle of the map. This particular multifocal contact lens that this patient is wearing is a center distance aspheric multifocal. So relatively speaking, we have the most minus power in the center, and then surrounded by that, we have the add as identified by that warmth. The steeper the curve, the warmer the color on our topographer. So we have that add going all the way around the center distance design. And what we can see is that this particular center distance multifocal is displaced in the temporal direction, just like we were talking about earlier. But what we've done on the bottom is it's the exact same patient, exact same eyes, it's the exact same multifocal design with one important difference, and that is that we've asked the manufacturer to move the optics, in this particular example, 1 millimeter in the nasal direction. So the lens fit is identical, nothing's different there. We've just asked the manufacturer to push those optics in the nasal direction, and now you can see that center distance zone is much better centered over their visual axis and within the patient's pupil. So if we look back up on top to those two images up on top, you can kind of see that this would be a potential scenario as to why a patient might be expressing that they can actually read better up close, yet the contact lens is intended to be a center distance multifocal lens. You're kind of left with your head scratching, but this is basically a picture of why that might be true for that specific clinical scenario. Well, one of the early questions that we asked at Pacific is, if this is an issue, what's average? And what we did was, in this particular investigation, we had 18 subjects, and what we wanted to do was bias things a little bit towards the quote-unquote normal eye, the normal patient. And the reason why we did that was we were going to take 5 currently commercially available soft multifocal lenses and then just try them on these subjects and then perform topography over the top of the lens and then see where is it that those multifocal optics line up with the patient's visual axis. So what we've done is selected those patients to have 43 diopter central K values, corneal toricity of less than a diopter, and then those individuals have a visible iris diameter of 11.8 millimeters plus or minus 0.2. And in so doing, after we allow the contact lenses to settle on the eye, we can start to see with our corneal topographer where is it that the quote-unquote optics are located. So what we have here is the Air Optix Aqua multifocal from Alcon, and this isn't necessarily intended to highlight any one particular product. What is, I guess, needed to know in this example is that this is a center near aspheric multifocal. That they'll become important here in just a little bit. But before we get there, this process that we're going through and looking what's happening in this tangential difference display is essentially the exact same process that we go through when we're looking at fitting someone with orthokeratology. What we have up on top, our top left, is their just normal cornea without a contact lens on. On the bottom left, we have a image taken over the top of that particular multifocal contact lens. In this case, it's a center near asphere. But what's most important on this slide is the image on the right-hand side, which is the difference display. And the reason why it's important to note it's a tangential display is this gives us a little bit better understanding of position. So in this center near aspheric lens, it's going to have its most plus power, or at least identified in terms of topography, the steepest curve. So it's going to have the, relatively speaking, warmest color. So this is that center near aspheric multifocal, the center of that ad, if you will. And then this white cross is the center of the map. That's where the patient's actually looking straight ahead. So what we can see here is that this particular multifocal lens is about 3/4 of a millimeter, something like that, in the temporal direction. How did I come up with that number? Each one of these grid lines is representative of 1 millimeter in size. So that's how that was identified. Well, what was the result? What was the average amount of mismatch? Well, if it was mismatched, and it wasn't always, but if it was always in the temporal direction. So there were some individuals that didn't have any kind of misalignment between the multifocal optics and their visual axis, which you could argue is kind of a picture of multifocal success. Like Lindsay highlighted earlier, there are many, many examples of patients that wear soft multifocal lenses of all varieties and brands very successfully. There are those, though, that seem to really struggle, where you get results that didn't necessarily match those of individuals that were successful. So on the high end, we saw individuals that had mismatches of greater than a millimeter, about 1.25 millimeters or so in the temporal direction. On average, though, it was about 0.5 millimeter. Some of our later work at Pacific and some other locations, I think that number is probably a little bit on the low side. We'll talk about some of those things in the coming slides. I think we're looking more greater numbers, even 0.75 of a millimeter than that. So, well, here's an example of a patient wearing a custom soft multifocal contact lens center near asphere. And what we can see here is that this lens is a geometrically centered optic. This is a quote-unquote standard optic, rotationally symmetric optic. And as we place this contact lens on the eye, in this right eye, that center near aspheric zone on this tangential difference display is in the temporal direction. And if we were then to ask the manufacturer to make everything about the contact lens identical, its distance power, its near power, the base curve, diameter, material, so on, except just to offset the optics, in this case, a ½ millimeter in the nasal direction. Now we've much better aligned those multifocal optics where the manufacturer intends them to be. The analogy I think of here is if we were to think of someone wearing a progressive edition spectacle, yet no one has ever taken a monocular PD on that particular patient. There might be individuals that would do well, you know, they kind of have an average PD, for example, and the patient would see well. But then there are those individuals that need a very custom, very special PD, you know, monocular PD, for example. So this is just kind of taking that multifocal optic just to the next iteration, to the next level, and really dialing it in for the patient. Well, we've kind of gone through some of the highlights, but let's kind of drill down and look at this a little bit more investigatively. And question number one in this particular study is it possible to analyze the optical centration of multifocal contact lenses with corneal topography? And I think that question's been answered a little bit by the previous study, but we wanted to sort of continue that theme and see if we were onto something here. Question number two is, what are the effects of offset multifocal contact lens optics on objective, sort of distance visual acuity, and then just their subjective response, clarity, fluctuation, ghosting, etc. Third question here is, does increasing the add power in the multifocal soft contact lens have an effect on objective and subjective vision? So let's get into it here and find out. So what we took were essentially 5 clinical emmetropes who had uncorrected visual acuity of 20/20 or better in both eyes, and ages 18 to 35, really no medical or ocular history. And then we're going to fit these groups, or sorry, these patients, or the subjects rather, into 3 different groups. Lens group number 1 will be a center distance aspheric lens with a distance zone of 2 millimeters. And then importantly, these are centered optics. So this is the traditional way in which we're used to thinking about multifocal lenses. And then we're going to have a series of different add powers, 1, 2, 3, and 4 diopters of plus. Next group of lenses here is the exact same thing we looked at in the first group, except now we're going to ask that the optics be offset nasally by ½ millimeter. And then third group, exact same lens design, except now we've offset nasally by a full millimeter. And this is really what it is that we're looking at. On the top, you can see those optics in their traditional centered geometrically centered fashion, and you can see there visual clarity, 4 out of 10, 10 being the best, 0 being the worst, visual fluctuations 6 out of 10, ghosting 6 out of 10, visual acuity right eye 20/30, left eye 20/40. Exact same lens design here, it's just now that we've offset it by a full millimeter in the nasal direction. Visual clarity now 8 out of 10. Fluctuation 9 out of 10, right eye, left eye 10 out of 10, ghosting 8 out of 10, right eye, ghosting in the left eye 9 out of 10, and then importantly, visual acuity bumps all the way up to 20/20, right and left eye. So summarizing points here is Snellen acuity and subjective vision were decreased with increasing temporal misalignment from the visual axis, and then increasing add powers decreased subjective vision, but did not have a statistically significant effect on Snellen acuity. What's meant there is that the patient can still achieve a level of vision on the eye chart. It's just that their subjective response to that wasn't as ideal as it would be in the lower add powers. Well, let's flesh this out a little bit further, kind of add some life to this by looking at case studies specifically. Patient essentially 42 diopter Ks, refraction now right around -5 in the right, -450 in the left, add power of a +150. Pupil size 3 millimeters, 3.3 or 3.4 in the right eye, left eye right at 4 millimeters. And then now what we can see here in a traditional centered optic here, this in the right eye is a distance center lens, and it is actually off by just over a millimeter of misalignment. In the left eye, this is a center near multifocal lens, and we're looking at about 0.9 millimeters of temporal misalignment, and you can see visual acuities there, both eyes open 20/20 minus, and the distance, both eyes open, left eye 20/30. If though we ask the manufacturer, if we ask Specialeyes to offset the optics in the nasal direction, this time by only 1/2 of a millimeter, we now much better center over their visual axis, and visual acuity still in the distance 20/20, but we've now really improved their near vision from 20/30 now to 20/20. So pretty impressive there. If we ask the individual their just subjective rating on a 1 to 10 scale, or excuse me, 0 to 10, 10 being the best, 0 being the absolute worst, the blue bar identifies no offset, and then the green bar identifies the nasal offset. What we can see here is at these different viewing targets, for example, in the distance, 20/30 target, it's a little bit better with the nasal offset, but where we really start to see the improvement is in the near vision. When we ask them to view about a 20/40 near target, you can see how much better we have ranked the near vision target with the offset lens than we do the 0 offset lens. And then the remainder of these bars here just identifying newspaper, cell phone, medicine bottle, and phone book. What I think is interesting is the more detailed the task, the greater the discrepancy in the subjective rating of their vision. So kind of an interesting finding in this N of 1. And with that, kind of hand it over here, and we'll increase the N just a little bit. So thank you.
Thank you, Matt. I find it funny because it's glad to know that the contact lens team over at the Michigan College of Optometry aren't the only crazy ones that pay this much attention to these optical axes, and take a look further at the topographies over top the lenses. In fact, you'll see some of the things that I talk about in the next few slides actually support some of the stuff that Matt's talked about. At the college's Vision Research Institute, Craig Norman, with his over 30 years of experience in the contact lens field, and I would often discuss the challenges in fitting patients with presbyopia. One of the challenges that seems kind of to have withstood the test of time is that something that I still struggle with today for my patients is this decrease in the quality of vision that we all know our patients that wear multifocal lenses seem to experience. If you think about it, Matt did say we are asking a lot from a very small piece of plastic. So whatever we can do to better understand how these lenses work with kind of the natural anatomy of the eye and not necessarily focus on geometric symmetry for ease of manufacturing may be able to see gains in some of these patients that are having some difficulty. So that's kind of the premise, which led us to a lunch meeting with the Specialeyes team at the Global Specialty Lens Symposium in 2017, where we discussed some of these challenges and wanted to devise a study where we could evaluate the impact on visual quality by varying the position of multifocal optics during the manufacturing process. So this poster that you guys see here on the screen, and I think I have control, yes. This was the poster that was presented at the 2018 Global Specialty Lens Symposium, and I'll get into the details of the study here. So the image here that you can see on the left eye, I think it's great because Matt mentioned this as well. Anyone who's actually looking at this image on the slide would probably call this lens on eye centered. This was one of the images that we looked at during the early stages when devising the protocol for the study and deciding how best to measure the lens centration and also the position of the optics in the lenses that we were going to be using for the study. So like I said, from behind the slit lamp, it's easy to see that this could be considered centered. These two triangles are equal in size, and for the most part, they are evenly positioned around the eye itself. So although I will say that the perception of depth is not necessarily incorporated, so that's just a side note. So that could be throwing off our concept of centration, but that's just something to keep in mind. This is obviously a still image, but even under a dynamic view, I consider this lens to be centered. When you look at the image on the right, so this is one of those difference maps. Matt did talk about how you would acquire this type of difference map, and you will get a more detailed description later in this presentation by Corinne as she describes how to acquire such a map. This map is generated from an acquisition taken over top a traditionally manufactured multifocal lens, so with those optics placed in the geometric center. So you can see in the area of where the green is, or the more positive power in this particular lens, that more minus power is here in the blue. So it's pretty obvious here that even when a patient is fixating in this straight ahead gaze, like what we ask them to do when they are sitting at the topographer, so the straight ahead gaze takes their visual axis where that white plus is, we can see that the optics clearly is not centered over that white plus. So if we take a look and on this image here towards the left, if we're following the convention then that the center of the map, like we've just discussed, is where the white cross is, coincides with their visual axis. It could also be called line of sight. That's just something that we, even in the group of the four of us here, we've discussed that literature tends to use the term interchangeably. Here we can again see that the near center and its position located centrally within the lens itself, if this is the lens outline. So if we look at this image here on the right, where I've kind of superimposed this dashed line here to outline where the lens is sitting on eye, you can better see from the outline of the lens that on this left eye, if we draw an imaginary line and dissect this lens, or bisect this lens, you can see that where the center of the near optics is, which is in the geometric center, again, would not align to where the visual axis is for this particular patient. So we can better understand why some of those decreases in subjective vision responses may occur, and we can definitely see these temporal decentration versus the image that I showed you in the slide before. This lens is clearly, you can see less overlap, like how Matt was talking about, towards the nasal side versus on the temporal side. So using these preliminary observations that yes, we can quantify and visualize where multifocal optics are located, what exactly was our study objective? We wanted to carry out a Ferris State University IRB approved study that was comparing a subject's objective and subjective visual response when wearing multifocal lenses, both with geometrically centered optics and lenses with optics that were displaced nasally by 1 millimeter. So what we know from today's presbyopic population is that they value a variety of activities that involve multiple working distances and various illuminations. Thus, a lens that works with the dynamics of the eye, regardless of the environment, is key. We chose to use instrumentation to standardize the room lighting conditions that we were using. We also had specific targets and set at specific working distances to assess lens performance. So we wanted to have subjects carry out near tasks that were as close as possible to real-world scenarios. What you're seeing here first on the left is the exact email that was presented to them on a smartphone, 5.7 inches smartphone screen size, and then you have a 2-page magazine spread. You see there's various font sizes, different contrasts, as well as color of font for them to take a look at. And then we also had a medicine bottle that was held at a set distance in order to assess visual performance. In total, we had 21 subjects where we were recruited and 42 eyes for this particular study. There were 20 subjects, my apologies, 40 eyes that had completed the study. And if we take a look at some of the demographics from the patient subject cohort, we had a pretty mixed range of ages in our presbyopic population here. The average age of almost 54. So we did have a mix of both early and mature presbyopes represented. Here we have our prescription ranges for sphere and cyl, and you can also see based on pupil size and the visible iris diameter, both measured under ambient light conditions, that when you take the averages, both of these parameters fell within what we considered the average range for eye shapes. Some of our baseline observations that were taken, you can see here, so all subjects came in for an initial study visit. If we're just going to talk about a little bit of the way that the study was carried out. Baseline topographies, Matt alluded to how you needed to have topographies taken without any lens on eye, so we did that during the first visit. Then we performed a diagnostic fitting, and we did that in the study conditions in order to ensure that the lenses were fitting properly. And then 2 sets of lenses were ordered, 1 pair with centered optics and 1 pair with 1 millimeter nasal offset optics. So both pairs of lenses were ordered with the correct prescription for each patient based on the individual spectacular fraction that was obtained during the first study visit. So when each subject returned for their second visit, and this was the final visit, they had the opportunity to try out each pair. So this was a randomized, non-dispense study, and it also incorporated a single-blind methodology. So subjects actually did not know what lens type they were, or what lens pair they were wearing for this non-dispense study. So again, everything occurred in office on that second visit. So some of the interesting observations from our baseline findings using the trial lenses was that all of the lenses, literally all of the lenses, so all 42 lenses that were placed on eye, had some degree of misalignment. So that's a little bit different from some of the observations that Matt made for our particular cohort here. And in this case, the near optic centers were located temporal. So not only was there always a misalignment, but they were always located, the near optic was located temporal in relation to where that patient's visual axis was. So this was the same observation for both the ordered prescription zero offset lenses as well. So the temporal positions you can see here from this chart below. So in the zero offset lenses, you can see this relatively higher positive value compared to the other numbers you see here on the screen. And the temporal position was denoted as positive. The negative average misalignment you see here for both the right and left eye shows us that some of the test lenses were observed to have more nasal misalignment than others. So that's where the negative number comes from. If we take a look at the topographies at the top, we see in the subject 1 example, first off, this is an early presbyope, so that's why you kind of see that there's a lighter, less of a distinct difference between where the center is in color. So it's a lighter blue versus the surrounding darker blue, versus the bottom, you can see it's more of a green color and compared to the blue. So there's a bigger difference between the powers there. This indicates at the top here, if you look at both subject 1 example and subject 2, you can appreciate 1 in the zero offset, there's a temporal misalignment. So if this is where the near optics is, the center of the optics is located temporal to where the visual axis is here in the left eye, as well as in this right eye, you can see there's your center for the visual axis, indicating the visual axis, and then the center of the optics is displaced temporal. So we can see that both from both of these topographies, and then you can see in the offset lenses were moved towards the nasal direction. So we had, again, variable amounts of that nasal, although it was 1 millimeter offset, it wasn't always mathematically 1 millimeter nasally displaced. And so you do still find that there was some sort of variation in how much millimeter off that nasal decentration was. And these very exact numbers come from the fact that in the topographer, we can ideally put our cursor at a point on the topographer and measure that metric value. So that's where we're getting these like to the 100th of a millimeter type of numbers coming through. So if we take a look now at some of the overall findings, the average binocular, if we're looking at quantity of vision, so we're looking now at logmar acuity, the average binocular distance visual acuity while wearing the 1 millimeter offset lenses and the 0 offset lenses was 0.08 and 0.11 respectively here. The average binocular near visual acuity, however, I think is where we see the biggest difference, and you can appreciate that by the difference in the bars here, was the 0.03 for the logmar acuity for the near VA with the 1 millimeter offset lenses, and then it was 0.09 with the 0 offset lenses. So when we ran the statistical analysis on these particular numbers, I mean, it's not, you don't need statistics to show you here. You can see the difference between the two, but there is actually no statistically significant difference in the distance visual acuity, logmar acuity, that is with either lens condition, but there is a statistically significant difference when it comes to the near vision acuities. So, I mean, if we think about it, these numbers that I'm telling you, if you were going to convert it to somewhere along what like Snellen acuity would be, you know, we're talking the difference between 20/25 minus and 20/20 plus a few letters. So while we have the statistically significance here, clinically significant is a very small difference. Where I think the biggest impact from this cohort that was found was more in the subjective responses. So what we did additionally was ask each subject to rate their binocular distance and near visual acuity, in addition to their ability to view the following specific targets held at set distances. So you saw where I showed you the article in the magazine. We asked them about their rating, their quality of vision. We asked them to rate the quality of vision while reading that email on the cell phone that I showed you, as well as their ability to read the usage instructions or the directions on the eye drop bottle that you saw. So specifically, each subject was asked on a scale from 1 to 10, with 10 being the best vision and 1 being the worst vision, how would you rate the quality of your vision? So there was a statistically significant difference in subjective responses with viewing the various targets. So 9 out of the 20 people that finished, 19 of the 20 people who completed the study favored the lens pair with the offset near optics. So we can see here, based on the numbers, we have this the subjective ratings, which correspond to the fact that I said there was no statistically significant difference in the logmar acuity. You can also see the distance visual acuity. There's not much of a difference between the two lens conditions, but in some of the tasks is where we see the bigger discrepancy. So from a conclusion standpoint, you know, the evaluation did find that that 1 millimeter nasal offset of near optics provided both a statistically and clinically significant difference for subject performance and preference when they viewed those various targets. Again, distance viewing was similar regardless of the lens pair worn. So although the difference in the near viewing is, you know, quantitatively equivalent to approximately 1 line of objective visual acuity, so that, like I said, from taking you from a 20/25 plus to maybe a 20/20 minus, subjectively the biggest difference is that increase in the quality of the vision. So examples of feedback that directly came from the subjects you're seeing here on your screen, with the lenses that had the 1 millimeter offset of the optics as compared to the 0 offset optics. You know, subjects were reporting that they don't have any of those overlapping letters anymore, less of a 3D effect. The double letters are now gone. They don't see halo around the letters anymore. And, you know, I'm sure any of you that are listening that have fit multifocal lenses have heard one, if not all of these from some of, at least one of your patients. So conclusion overall is that quality of vision can be improved by nasally decentering the optics in these particular near center multifocal lenses. So with that, I will hand it over to Corinne, who will discuss more detail as to how to acquire these measurements.
Okay, great. Thank you so much, Dr. Ramdass. Now, we are going to discuss a few methods for identifying a multifocal misalignment issue so that you'll know when to prescribe with OptiSync technology. And tonight, we'll briefly review the methods that you see on the screen, but we'll also, at the end of the webinar, have a link to our document, 3 Ways to Identify a Misalignment, which will review each of these methods with some more detail and step-by-step instructions. So let's go ahead and get started with our first method. One way that you can identify a misalignment is to compare topography of your patient's bare cornea to topography taken over top of the multifocal contact lens. And at Specialeyes, we really like this method for a couple reasons. Number one, this is the method that was used in the studies that Dr. Lampa and Dr. Ramdass just shared with you. And number two, this is the only method that tells us the whole story, including the on-eye lens performance. And it really gives us the ability to determine how much misalignment is present and how much we'll need to offset the optics to improve the outcome. And so utilizing your topographer's difference display function, some might call this the subtractive or comparative map function. You'll want to select the baseline map first, which is what we see here in the upper left-hand map. And then you'll want to select the map taken over top of the multifocal contact lens, which is what we see here in the lower left-hand map. And to highlight the appearance of the multifocal optics, like Dr. Lampa and Dr. Ramdass said, make sure that the maps are being displayed in tangential power. And depending on the make and model of your topographer, this setting might be called tangential or curvature or instantaneous. And one other thing I'd like to mention, if you're going to use an in-office multifocal design, I would suggest that you select a lens with a higher add power. That's just going to help make it easier for you to see the center of the optics in relation to the visual axis, like you saw in the studies that we just went over. And once you deploy that difference display, a third comparative map will automatically be generated here next to the 2 original maps. And that's what we see here in the larger map to the right. And sometimes determining the location of the optics can be a bit challenging, so you can actually enhance the appearance of the optics by adjusting the color display scale. Now keep in mind that that scaling will vary based on the power of the lens that's ordered, so you may need to experiment with a couple different scale steps until you can clearly see the center of the optics. And then finally, by using your topographer's ruler or white cross tool, you can measure how much, if any, misalignment is present by measuring from the center of the map to the center of the optics. And again, as long as that patient is fixated down the axis of the instrument during capture, the center of the map can be used to estimate the location of the patient's visual axis. So in our example on the screen, you can see there's approximately 1.14 millimeters of misalignment present. And we believe that patients with a 0.5 millimeter or more of misalignment will likely experience an improvement with OptiSync technology. So this patient would definitely be an ideal candidate for the customization feature. Another way that you can predict a misalignment between the optics and the visual axis is by examining your patient's angle kappa value. So what is angle kappa? Well, when we look at the image here on the slide, you can see that the visual axis is displaced nasally from the pupillary center, while the fovea is positioned temporally. And the angular distance that's created between the visual axis and the pupillary axis is the angle kappa. So why does this matter? Well, just like multifocal IOL patients, when multifocal contact lens patients have a small angle kappa, light travels through the center of the lens to the fovea and provides balanced vision. However, when patients have a large angle kappa, light may pass through the edge of a multifocal optic zone, and that causes reduced acuity and these unwanted complaints of halos, glare, shadows, 3D vision, all of the things that we've probably all heard when fitting multifocals. And while most diagnostic instruments don't automatically calculate angle kappa, it can be estimated by examining the X and Y pupil center coordinates. And when looking at these values, the X coordinate represents the horizontal meridian, while the Y coordinate represents the vertical meridian. And here's an example of those values taken with the Oculus keratograph. The white dot in the center of the map represents the corneal vertex, which again is used to estimate the location of the visual axis. The dashed circle represents the pupil diameter, and the black cross signifies the center of the pupil. So with a quick glance, we can clearly see that the center of this patient's left pupil is positioned 0.47 millimeters in the temporal direction and 0.17 millimeters in the superior direction from the visual axis. Now, some experts have suggested that when the value in the horizontal meridian goes beyond a 0.5 millimeter, the patient will start to have issues in soft multifocals due to large angle kappa. So when we're looking at these values, pay particular attention to that X pupil center coordinate and be on the lookout for the values beyond a 0.5 millimeter. Now, keep in mind, every topographer has different software and measurement capabilities. So if you have some specific questions on what your device can do, how to obtain these values, I would encourage you to reach out to your device manufacturer for assistance because they are going to be the experts on how to obtain this. Now, there are some devices that have both corneal topography and wavefront capabilities that can automatically calculate angle kappa for you. And a great example of this would be the Nidec OPD3 scan sold by Marco. This device can actually measure angle kappa in both photopic and mesopic conditions. So let's take a look at the values here in the bottom right-hand corner of the map. The P-dist value represents the patient's angle kappa in photopic conditions, and the M-dist represents the patient's angle kappa in mesopic conditions. And one practitioner who really has been vital to our understanding of why angle kappa matters when we fit multifocal contacts is Dr. Timothy Petito. With his experience using the OPD, he's actually found that 100% of patients with an angle kappa greater than 0.7 millimeters will fail in traditional multifocal contact lenses due to a misalignment associated with a large angle kappa. Now, this particular patient on the screen has a large angle kappa of 0.72 millimeters. So according to Dr. Petito's experience, traditional multifocal contact lenses simply will not achieve a truly successful outcome and would definitely benefit from offsetting the optics. Now, before we kind of move on to the next slide, I just want to make mention that angle kappa values are simply a way to predict a potential misalignment issue. It's just one piece of the puzzle, and unlike over-topography, it really doesn't account for the on-eye lens performance. So your patient might have a small angle kappa but still suffer from a misalignment issue if the lens itself decenters or there are other underlying factors at play. Now, with that said, we've taken some information from ophthalmology literature, our internal studies, and clinical feedback from Dr. Petito and other experts, and we've created some guidelines for identifying or predicting a misalignment issue using angle kappa. So 0 to 0.3 millimeters, a misalignment issue is not likely, and we wouldn't recommend starting the patient in a design with OptiSync based on their angle kappa value alone. 0.31 to 0.59, it indicates a possible misalignment issue. And again, these values don't account for the on-eye lens performance, so you may want to consider some further testing using over-topography or clinical intuition, which we're going to discuss here in a few moments. And then if your patient has an angle kappa of 0.6 millimeters or greater, based on that value, a misalignment issue is very likely. And these patients would probably benefit from starting in a lens with OptiSync technology. And just to wrap up our discussion here on angle kappa, I just want to review a few of the trends associated with it so you'll know what to be on the lookout for in practice. Research has shown that gender is not related to angle kappa. Large angle kappa values are more prevalent in hyperopic patients compared to myopic patients. So if you have a hyperopic patient that's been struggling in a multifocal contact lens, check to see if maybe the large angle kappa could be a cause. Angle kappa tends to be larger in non-dominant eyes compared to dominant eyes, and since most of the time the right eye is dominant, we could hypothesize that this may be the reason that angle kappa tends to be larger in left eyes compared to right eyes. And actually, this last bullet point correlates with our misalignment study data that found right eyes to have an average misalignment of 0.67 millimeters, and left eyes to have an average misalignment of 0.76 millimeters. Now, if you don't have a topographer or wavefront device in your office, you can still use your clinical intuition to identify and predict a misalignment issue by assessing their chief complaints and visual symptoms. So some of the symptoms that are associated with a misalignment include poor near vision in a near center lens, poor distance vision in a distance center lens, shadows, 3D, double vision, those subjective complaints of flare and halos, and you may have even heard your patients say something like, if I just tilt my head in one direction or change my gaze, I can see better. All of that, all of those symptoms are associated with a misalignment, but just because your patient has one or more of these symptoms, it doesn't necessarily mean that they're suffering from a misalignment. These symptoms could be related to factors like a poor lens fit, larger or smaller than average pupil size, under or overcorrected refractive errors, etc. So if your patient does have one or more of these symptoms, the next steps are to rule out any other underlying causes. So first, you want to make sure that the lenses provide optimal fit and good comfort. Take some extra time with that slit lamp evaluation and critically observe the centration. Is the lens truly centered with equal coverage on all sides of the limbus, or does it sit slightly temporal? And if the lens is slightly decentered, do we have room to try a smaller diameter and or steeper base curve to improve the centration first, or is the fit as good as it's going to get? Next, you want to make sure you have that solid refraction at distance and near, and that you've incorporated those powers into the lens design. And then finally, evaluate your patient's pupil size and regular room illumination. If the patient has a smaller or larger than average pupil size, you actually may want to start with one of our pupil optimized designs without OptiSync technology first. And then if you've addressed or ruled out all of those other potential causes and you still suspect a misalignment issue, contact us at Specialeyes, ask for consultation, and we would be happy to help you design a set of lenses with offset optics. And then just to review a few of the ordering and fit guidelines, for now, OptiSync technology is going to be available for spherical multifocal contact lens patients only, but we will be hoping to have that toric available to you soon. And when you call to order, the first thing that we want you to do is identify a misalignment. And as I mentioned earlier, we have a fantastic document available with some detailed instructions for each of the 3 ways we discussed tonight. And depending on the devices you have in office, you may even want to combine a few of these methods. For example, let's say you have a patient who's failed in virtually every in-office multifocal design. No matter what you do, they're just not satisfied with vision and they keep complaining of these symptoms associated with a misalignment. At this point, your clinical intuition may be saying, I think there's a misalignment present. I think they might need offset optics, might need OptiSync technology, but you might want to take this a step further to be sure. If you have a topographer or wavefront device in your office, at this point, you could examine the angle Kappa, you could perform topography over top of the multifocal lenses, or both to confirm your suspicions. Step 2, work with consultation to design trial lenses. To design an initial set of trials, we'll ask for your patient's K readings, HVID, refraction, pupil size, and any prior lens wear history. Once we design those trial lenses, we'll send them to you and you should have them in your office within 4 business days. And then step 3, once you have the lenses on the eye, perform a thorough evaluation of the lens performance, make sure it fits well, take visual acuities, and if changes are needed to improve fit, comfort, or vision, just record those details and contact consultation for assistance, and we'll be happy to help you modify those lenses. And I think that about wraps everything up, so I'm going to turn it over to Adam.
Great. All right. Well, thank you so much. So this was a really informative webinar. In fact, what's really funny about it, I can get the audience view here. I can see that we retained 100% of the audience tonight. So congratulations, everyone. You stuck around. I want to mention also that you can see that the PDF, and let me actually see if I can find it here. On the right side of your screen, if you'd like to download a copy of that PDF, there's a thing that says handouts. And if you click on that, that's actually that PDF on how to identify misalignment. And if for some reason you can't download it here, I'll also post the PDF up on ODwire and it'll be available beneath this video. So why don't we get to some questions here? We have a few minutes left so people can chime on in. So let's take a look here and let's see. I'm going to ask a question first, and I'll throw it out to all of you guys so you can answer this for me. Knowing the difficulties that some people have had fitting multifocals in the past, would you recommend using the instrumentation to look for a misalignment straight out of the get-go instead of waiting to see if there's a problem? And feel free, whoever wants to try to answer it.
Adam, a couple of our practitioners actually do take it from the end. Before they even order the set of lenses, they use their instrumentation to evaluate the angle kappa values, and kind of talk about any prior lens wear history that the patient may have had in another office, and kind of get a good sense of what the patient's been experiencing, see if they can identify it first, and then they may even use an in-office multifocal to do some topography over, and before they even step into ordering a specialized lens. So I would say there's a subset of practitioners out there that have done that, and have this process built into their practice that makes it easy for them to kind of identify it from the beginning and start off on the right foot to success.
Right. Question here, and I don't know, Corinne, you may be able to answer this, or maybe even Lindsay can, or maybe both of you. Typically, when you get these trials made up, how many trials does someone go through before they get the fit right?
Yeah, that's kind of a broad question, Adam. However, that one thing we know, looking at data outside of OptiSync, since OptiSync obviously is a new product, we're going to, since we launched, we'll be watching it closely. But with all of our other products, we find that when we have solid information up front, that a large percentage of our patients are successful in 1 to 2 trial lenses. Corinne, do you remember the exact stat on that from the data that was looked into?
I would have to pull it to give you an exact figure. I apologize, I don't know it right off the top of my head. But
it's in 70% range, correct? Within 1 to 2 trials?
Yes, exactly. Okay. Exactly, yes, definitely within the 70% range. It's 76 or 78%. I'm not exactly sure, but yes.
Great. Question here, not everyone has the equipment that they might need yet to fit these lenses. The question is, can you provide what types or models of topographers you think might work best for doing this?
So in regards to the studies that we've conducted and the information that Dr. Lampa and Dr. Ramdass has shared, the majority of it has been done with the Medmont corneal topographer. As Corinne mentioned, we've worked with Dr. Timothy Petito in regards to using the OPD that is sold by Marco. It's the Nidec OPD3. And if they download that Identify Multifocal Misalignment document, in that document, there's an example of over-topography with the Medmont. And then there's a nice example of evaluating angle kappa and angle alpha values with the OPD. And Dr. Timothy Petito actually goes through a case study in that document showing the full process. And that's a really good example to look at. We're not biased towards any one topographer. I mean, we have practitioners that send us topography from all sorts of different devices. And like Corinne showed in the presentation, we've used the Keratograph 5M as well. So I'd hate to recommend a certain topographer for this use, just because, I mean, there's a lot of good topographers out there. Maybe Dr. Lampa and Dr. Ramdass could, chime in from their clinical experience with topographers. But as far as we're concerned, I mean, we have a lot of different topographers where practitioners send us maps from, and there's a lot of good topographers out there. But all of the study data has been with the Medmont.
Right.
I can add that, a lot of the manipulation that we did, we looked at, and Matt mentioned it as well, it's looking at tangential maps. So I think it's more so the capabilities of maybe some of the software for the instrument. If you have that ability to manipulate, to get numerical values at certain points on the map, to take different types of maps, that would be your best bet if you can get an instrument, or you're deciding what type of instrument to acquire.
Yeah, and to just add what we're saying there is, if that topographer not only has the ability to do tangential display, but if on that tangential difference display, if that particular topographer has the ability to adjust the scale, that will really be able to highlight where some of these add powers might be located, because as was mentioned, in the lower add powers, it can be hard to see. The higher add powers are much more easily seen because there's a greater discrepancy between the add and whatever distance correction the patient has. So that'd be the key things I'd look at when I'm evaluating a topographer for this particular purpose. It would be the exact same thing though if you're going to use the topographer for Ortho K, like the exact same features would apply. So yeah.
Right. Question here. So the examples that you ran through, you talked about decentration sort of in the east and west directions, but what about north-south? Have you looked at that and the impact on vision? Does it decrease the subjective vision in a similar way?
Good question. So the study that I mentioned as a part of my part, where it was a distance center optic in that particular multifocal, when we asked individuals to actually reach up and manipulate the lens that was geometrically centered so that they could see better, they all moved it in the nasal direction, which is like we've highlighted here, but they also moved the lens up a little bit. So there hasn't been, when we've looked at this, there hasn't been too much in the vertical direction, but if I had to say, if we needed to move it in a direction, it would probably be in the superior direction.
And Dr. Ramdass, would you like to, we had some data from the Michigan College of Optometry study looking at superior versus inferior location. Do you want to comment on that or no?
Yeah, the majority of, I mean, based on what we know anatomically, if we're going to look at where that fovea tends to be decentered and where our visual axis is decentered, I will agree with Matt. It's in that superior, that upper quadrant in where we saw the majority of that decentration or that misalignment occurring, where the potential, that actual cohort, it's not 100%. So we did have some variability though. So it's more of like a clinical inkling as opposed to being hard science at this point in time from our particular study.
Right. Question here, the best way to measure pupil size. So do you do it with normal room illumination with a pupil ruler or with topography, or how do you recommend people do it?
Yeah, so basically with whatever device they have in office, the two pieces of information we need when obtaining a pupil measurement for lens design would be what's the device used to measure, whether that's a topographer, whether it's just a PD ruler or some type of other device, integrated loop into the slit lamp. Let us know the device used to measure and the lighting of the room during the measurement. So a lot of topographers, like for instance, the Medmont versus the Keratograph 5M, I mean, they have different light sources within them that are going to affect pupil constriction or dilation. So at Specialeyes, we've done a lot of internal work on knowing what device does what and how that lighting from the instrument during the capture will influence the pupil. And we account for some of that during the lens design process. So as long as they just let us know the device used to measure and the lighting of the room during capture, that will be perfect. And then just take extra special care in obtaining that measurement.
Right. Question here. Are you planning to do a study with post-refractive surgery patients, including RK?
Not that I'm aware of. Nothing on, in the works right now.
Right. Great. Interesting comment here. I guess not even a question, but a comment. But why not just decenter all lenses by 0.5 millimeter nasally? Statistically, wouldn't this be a better option for better vision?
Yeah, I mean, that's an interesting comment. And I think like as the amount of data, as that data grows, we're going to learn more. And who knows, maybe down the road, things will move that way. The one thing I will say, though, in regards to that, when we offset the optics, we obviously have to have a way to stabilize the lens due to the offsetting of the optics. So a good note to make that I don't think we mentioned in the webinar is if you do order a lens with OptiSync technology and it has a spherical prescription, the lens will come with stabilization and diagnostic marks, and that's due to the stabilizing of the lens because of the offsetting of the optics. So, but that's a great point to make, and who knows, as we gather more data and learn more about this, I'm sure things down the road will kind of evolve and we'll continue to iterate and move forward with technology, and maybe that'll be the case down the road. It'll be interesting to see how this unfolds.
Right, so speaking of stabilization, we have time for one more question, and the question is, are all the lenses that were used in the study prism ballasted to prevent rotational differences that might move the center of the optics around?
Yes, all of the lenses were prism ballasted.
Cool, All right. Well, it looks like we're running a little bit short on time. Did you guys want to sort of leave us with any parting statements?
Just appreciation for everybody's time and joining us here for the webinar. We really appreciate it. And then Adam, if maybe you want to put up the last slide, the next slide, it has the one after the Q&A, it has our contact information, our phone number, and then our email to our consultation team. Corinne is the lead consultant. So if you have any questions afterwards, you need to reach out, please feel free to reach out with us, reach out to us at any time. We'd be glad to discuss things further.
Fantastic. And, this talk will be up on ODwire, and, there's going to be a discussion going on beneath it. So I encourage everyone with more questions to come on out and ask away, and we'll get a really good discussion going. So thanks again, everyone, for being here tonight, and I look forward to seeing everyone online.